Hello, good morning.
They can hear you, can continue.
All right, good morning, students. You are welcome to today's facilitation. The course is ANA 212, Regional Anatomy, and my name is Ogundipe Olukemi. So I'll be the one to take you on this course this morning. And as you know, it's a revision class. So we will try as much as possible to touch everywhere and tell you the salient points that will be needed. ANA 212 is regional anatomy. And during first semester program, you started that course and it was tagged ANA 211 then, and it was systemic and functional anatomy during ANA 211 first semester. But during this semester, it is regional anatomy. We will be studying anatomy in regions. And the outline for this discussion this morning, you shall be introduced to regional anatomy. So we shall discuss the regions of the head, the regions of the face, the neck. Then we shall go on to discuss the region of the thorax. We shall briefly discuss the arms, the upper limbs, then the lower limbs. Now let's kickstart by discussing what regional anatomy is. Just like I've said, regional anatomy is the study of interrelationship of all the structures in a specific body region. So the body is divided into regions. I know there are some specific organs within a specified region. So that is basically what we shall be discussing this morning. And in other words, regional anatomy is also to describe the location of that organ, the position of each organ, the layers and the related causes and their interrelationship in human body. So how every structure is related to each other. You know, God is so magnanimous to connect every structure in a body that they function depending, no organ of the body can function independently, but they all depend on each other to carry out their function. So as we go on in this discussion, we shall discuss the anatomical position and directional terms. Anatomical position and directional terms. And as nurses, we need to be conversant with these positions and the terms used, though we are not anatomists, but there is no way we can carry out our activities in the clinical area, even in academic area, without having the knowledge of the anatomical position and the directional terms. And in essence, anatomical position of the body is the precision which is generally accepted as a standard by the anatomists as the way in which the body will be viewed. So in this context, you know, I said it's a standard. It shows that a particular position here in Nigeria is accepted everywhere in the world. So it's not as if it is limited or it is localized to a particular region or a particular hospital, but it is a universal standard. Now, talking of directional terms, this one describes the position of structure relative to other structure or location in the body. So when you are talking about directional terms, you know it is in relative. There is no how you can actually discuss a term without making reference to another structure of the body. Now, the slide you'll be seeing on your screen now, it will show you some anatomical positions that we use when we describe the body structure. I am sure you can view that structure on your screen. From that structure, you discover that that is a picture or a structure of a whole body from the head to toes. And I'm sure you are able to view those structures very well. You know, from the upper, you can see from the head, you can see superior. That is a term. Inferior, then you have, you know, when you talk about superior, you know that the opposite of it is inferior. You know, that one is even grammar, not even medical this time around. Then, you know, medically, when you talk about media, you know, you begin to think about lateral. Then when you talk about proxima, you think about distal. And you know, when you talk about anterior, you talk about posterior. And you know, anterior can be otherwise called ventral, while posterior can be otherwise called dorsal. Then at the same time, you know, when you are talking about superior, you know, you are talking about the cephalic term, and you know, when you are talking about inferior, you know, you are talking about the caudal. So in the next slide, I'll briefly define each terms and how they can be related in the body. This is particularly important for us as nurses. You know, when we discuss, especially when we are in the hospital settings where you are having discussion with other people in the medical field, you don't have to behave as a novice. You have to talk professionally so that people will know that indeed you are a professional nurse. So, and this one is one of those factors that distinguish you from people that are not professional, that are calling themselves nurses. Now, let's quickly go through each of those terms. From your screen, you can see, you know, I told you anterior means ventral. And what anterior discusses is that it describes the front or the direction towards the front of the body. You know, when you talk about anterior, you begin to think anything in the front. And the example you can quickly take note is that you can see the toes are anterior to the foot. You know, just begin to imagine as I am discussing. The toes are actually in front of the foot. And that's why, you know, and I had already told you that anterior position describes it describes the front direction regarding the body. Then the opposite of anterior is posterior. And you know, I told you it's otherwise called dorsal. And this one describes the position towards the back of the body. It describes the position towards the back of the body. And then let's go on by discussing superior position. You know, I told you in that diagram that I showed you before this slide that superior is otherwise known as crania. And you know, when you say something is superior, even in ordinary English term, when you say something is superior, it is upper, it is high, it is above. So anything, any structure that is upper or in the upper end of the body is described as being in superior position. And you know, when you are talking about position, when you are talking about superior, you describe it in relation to the head. And inferior position describes a position below or lower than the other part of the body. And most often than not, it describes a position that is at the lower part of the body, especially when you are putting two structures you got me while I was discussing the superior and the inferior aspect of the terms used in anatomy. So let us proceed as we discuss the lateral term. And you know, when you talk about the lateral term, it describes the position away from the midline of the body. You know, when the body is divided in the midline, so the position away from that midline is what we called lateral position. And the opposite of that one is the medial position. I know the medial position describes the position towards the midline of the body, that is the middle of the body. I hope you are getting me. Then let us continue as we describe proxima. For proxima term, it describes a position towards or nearest the trunk of the points of origin of a part. I know when we are discussing proxima and distal, most of the time we discuss it in relation to the limbs. And the example is that the proximal end of the femur joins with the pelvic bone. You will discover that we still get to the femur bone when we want to describe it. You know, the proxima is the one nearest to the trunk or to a point of origin of a particular limb. So that's why I am taking femur bone as an example. So the proximal part of it is the head of the femur, and we can say that it's proxima, that the proximal end of the femur joins with the bone, the pelvic bone. Now, just like I said, when you discuss proxima, you begin to think about distal. So for distal position, it describes a position away from or farthest from the trunk or a point of origin. So, you know, proxima means near to the point of origin, while distal means it is far away from the point of origin or from the trunk. Then, you know, I think I've dwelled on the superficial and the deep. You know, when you discuss superficial means something at the periphery. It is very closer to the surface of the body. That is the superficial position. And you know, the example displayed on your screen is that the skin is superficial to the bone. And you know, when you discuss deep as an anatomical position, deep describe a position further from the surface of the body. You know, it is further from the surface of the body. And you know, from the grammatical view, you can even think about what deep means. It shows that it is inside, it is within. And you know, the example that I'll give there is that the brain is deep inside the skull. And I will want you to take note of these anatomical positions in terms. They are very, very important, and the way and manner we apply it to our practice matter. It shows how knowledgeable we are in the field of anatomy. I will have no option but to cite this example. In one of the exams, definitely not for your class, they were asked to describe some of these positions, and deep is one of those positions they were asked to describe. You know, a nurse was describing deep. Fine, he or she described that position as being far from the surface. But when he wanted to give example, he was giving unrelated examples, saying that the stomach, the liver is deep inside the stomach. You know, it's very funny, and as a nurse, a professional nurse who has at least basic knowledge of anatomy, we should be able to know all these things and relate them well using human body. Somebody was describing distal as a position that is far and was trying to say the television is far from the child. Fine, distal means something is far away, but you make your description in relation to human body, not an object. I hope you are getting me. Let us proceed on as we discuss the planes of the body. You know, for the planes of the body, from the illustration you are having on your screen, basically we have three planes of the body. We have the sagittal plane, the frontal plane, which is otherwise known as the coronal plane, and we have the transverse plane. Though some authorities will put oblique as one of those planes, but oblique is a form of transverse. It's a form of transverse plane. As I go on in my discussion, you understand better. But basically, there are three planes that are basically discussed when it comes to anatomy, and it is the sagittal, the frontal, and the transverse. Now, let me quickly tell you what each of those planes, what they mean. Now, just like I said, the body planes, they are imaginary surface or planes, lines that divide the body into sections. So when we talk about planes, they are just imaginary. It's not as if you can see sagittal or you can see, okay, it's not as if you can see sagittal or you can see frontal, but you just imagine. Now, let me take sagittal plane as an example. It is the plane that divides the body or an organ vertically into the right and left sides. I hope you got that. So sagittal plane divides the body vertically into the right and left side. And when you're talking about sagittal plane, you can have parasagittal or mid-sagittal plane. For parasagittal plane, this one divides the body into two unequal right and left side. So it doesn't, parasagittal doesn't really mean it's going to be equal, though it's still dividing the body into two sides, but they might be unequal. For mid-sagittal plane, this one is also a vertical division, and it's just from the middle of the body. It's just like the name implies, it divides body into the right and left sides. For the frontal plane, you know, I told you the frontal plane is otherwise known as the coronal plane. In this position, I mean, in this context rather, the plane is a plane that divides the body or an organ into the anterior and posterior parts. I'm sure you are following me, and that is why you don't have to discuss the terms or the anatomical terms before we come into this. You know, when you talk about the anterior, it shows that for frontal plane, this time around is not right and left position, but the front parts and the posterior part, that is the rear, the back part. I'm sure from the illustration I gave before this explanation, you could get it better. And for transverse plane, in this context, the body is divided horizontally into upper and lower portion. I hope you actually got the difference between these planes rightly. For transverse, it is horizontal division, but for sagittal, it is vertical division. And for frontal, you know, the body is divided into the anterior and posterior position. Now, let us move on as we discuss the body cavities, or what is called the cavities of the body. What is body cavities? How can you describe a body cavity? A body cavity is any space or compartment or a potential space in human body. And funny thing is that what this cavity does is that it accommodates organs and other body structures. It accommodates organs and other body structures. And in anatomy, you describe body cavities as either ventral or dorsal. The ventral aspect of it is that it is anterior, and the ventral is much larger than the dorsal position. Then, you know, when I said the ventral is larger, definitely the dorsal is smaller. Now, for ventral position, for ventral cavity, it constitutes the thoracic cavity and the abdominopelvic body cavity. Those are the parts or what makes the content of the ventral cavity. But for the dorsal cavity, it is basically the cranial cavity and the cranial cavity and the spinal cavity. For the dorsal cavity, you know, I told you the thoracic cavity will still get there as we discussed on, and then the abdominopelvic cavity. let me quickly say something about abdominopelvic cavity. Actually, we call it abdominopelvic cavity because the abdominal cavity is in continuation with the pelvic body cavity. And I want to let you know that when we talk about abdominal cavity, you can discuss abdominal cavity in region and also in quadrants. I'm sure from the knowledge of your basic anatomy from your different basic schools of nursing, you know, when you talk about abdominal quadrants, there are 4. You have the right and quadrants, and you know the quadrants are divided into 4, and also the regions. There are 9 regions, 9 abdominal regions. And when you talk about the abdominal regions, you think about the right hypochondric region, and you also you discuss about, you know, when you have right hypochondral region, you have left hypochondral region. Then you have lumbar region, and you have umbilical region. Then you have iliac region. Then you have hypogastric region. I think I've not confused you. There are 9 regions, and there are 4 abdominal quadrants. And you need to know the structure that can be found in each region and in each quadrant. That makes you a good nurse. You know, especially when you are making abdominal palpation, you know, having the knowledge of the structures that are in this region, you'll be able to palpate better. I wouldn't imagine a nurse claiming that she's palpating the uterus in abdominal cavity when the woman is not pregnant, or when the woman does not have any pathological problem. Because under normal condition, the uterus is a pelvic organ. So it shouldn't be palpated abdominally unless the woman is pregnant or the woman has a tumor that makes the uterus to grow out of the pelvic cavity to become an abdominal cavity. I hope you are following me. Now, having said that, let us discuss the region of the head. The region of the head. The head consists of the brain. It's protective covering, that is the meninges. You know, from the head and from the structure you can see on your screen, you have the ear, the face as part of the structures that make up the head region. Now, when you discuss the cranium is actually the skull. It's also that is otherwise known as the skull, and the skeletal structure of the head. And you know what does it do? It supports and protects the organs within it. It supports and protects the organs within it. Now, still in the region of the head, the cranium can be divided into a neurocranium, and that neurocranium is called the cranial vault. So the cranial vault is the bony structure, the big bony covering of the brain, and it is membranous covering. That is, the neurocranium is the cranial vault, and it covers the brain and the meninges. There are 8 bones that form the neurocranium. So out of the 8 bones, we have 4 single, or what we can say singular bone, and we have 2 sets of bilateral bones. That is, they are pair. We have 2 sets that are pair. And you know, if you add the 4 single bone and the 2 pair bones, it makes 8 bones that form the neurocranium, that is the cranial vault. So for those singular bones, we have the frontal bones, we have the ethmoid, the sphenoid, and the occipital bone. And the 2 pair bone that make the neurocranium are the temporal and the parietal bone. Now, having said that, the other aspects of the region of the head is the viscerocranium. The viscerocranium is the facial skeleton. And it forms the anterior part of the cranium. it forms the anterior part of the cranium, and it consists of bones surrounding the mouth, the nose, and most of the orbits. I'm sure when we talk about orbits, we are referring to the eye. For this part, there are 15 irregular bones that form the visceral cranium. We have 3 singular bones, and those singular bones are the mandible, the ethmoid, and the vomer bones. So we have 6 paired bones, and these 6 paired bones, they are the maxilla, inferior nasal concave, the zygomatic, the palatine, and the nasal bone itself. So in all, there are 22 bones of the skull in an adult, though I want you to take note of this, that mandible is the only movable bone of the bone that make up the region of the head. I am sure you are following me. Now, the table that will be displayed now will show brief descriptions of the bones we have mentioned, and I'm sure they are also contained in your lecture notes. So this is just a form of refreshing your memory. You can get the details of this description in your lecture notes. Just like I said, ethmoid is one. And how will you describe the ethmoid bone? It forms the base of the cranium and also part of the cranial floor. There, it is anterior. It is anterior to the body of the sphenoid, and it contains ethmoidal sinuses. The descriptions is like that. Then the frontal bone, I told you the frontal bone is also one. Though somebody may begin to think that when you discuss the fetal skull, that the frontal bone in the fetal skull, there are 2, but you remember that in a newly born baby, the frontal bone might be 2, but eventually as the child begins to grow, the frontal bone fused to a singular bone. And that is why I am discussing frontal as one, because we are discussing the bones that make up an adult or an adult head, not a fetal head. So frontal bone is one. It is anterior and superior part of the cranium. Remember those anatomical terms. The anterior, it is anterior towards the front, and also the superior above. Then the shape is like scoop. You know what scoop is? Something you can use to get maybe food out of a container. It's a little bit hollow. So the shape is like a scoop. It protects the front of the brain, and it contains passageway for nerves and blood vessel. Then for the occipital bone, I told you it's also one. It is the posterior part of the cranium. So you can begin to think when frontal bone is anterior, the occipital bone is posterior. And for the occipital bone, it includes the base and slightly curved plate that protect the posterior part of the brain. So it forms the foramen for spinal cord and nerves, and site for attachment of muscles and ligaments. Then parietal bones are 2, just like there are 2 in a fetal skull. They also form the superior side. At this time around, they are at the side, but they are still superior side and the roof of the cranium. They are in between the frontal bone and the occipital bone. I think you can figure it out the way I am describing it. The parietal bone, they form the superior part, and they are in between the frontal bone and the occipital bone. So they also protect the top side of the brain, and they also provide passage for blood vessels. So they provide passageway for blood vessels. For sphenoid bone, it also forms the base of the cranium. It is anterior to the occipital and temporal bones. So sphenoid bone is wedge shaped. So it houses, take note of this, it houses the pituitary gland, and it contains the foramen for cranial nerves, meningeal artery to the brain. Then for the temporal bones, they are 2. And they are the side and the base of the cranium. So they are made up of squamous, petrous, tympanic, and they contain a zygomatic process then mandibular fossa, then air ossicles, and mastoid sinuses. So basically, I have been able to discuss the bones that form the region of the head. Now, there's another structure that we need to mention as we proceed, and that structure is what is called the scalp. It is what is called the scalp. You know, the scalp is the covering of the bony aspect of the brain. So the name is scalp, and how to describe it, the mnemonics to describe this is also, that scalp is also used in the description of scalp. I don't know if I'm confusing you, but let me just say something about it. You know, S stands for the skin, and the skin contains many sweat and sebaceous glands and hair follicles. So it has an abundant and arterial supply and good venous and lymphatic drainage. So that is the outermost part of the skull. So the outermost part of the scalp, rather. So the outermost part of the scalp is the skin. So next to it is the connective tissue. And with connective tissue, it is thick, it is dense, it is highly vascularized, and you know, it's subcutaneous layer, and it is well supplied with cutaneous nerve. So the next to connective tissue is the aponeurosis. For aponeurosis, it's a strong tendinous sheet that covers the calvaria, and it serves as attachment for frontal and occipital belly of the occipitofrontalis muscle and the superior auricular muscle. And you know, collectively, these structures form the musculo-aponeurotic epicranium. So the next layer of the scalp is the loose connective tissue. The loose connective tissue is sponge-like layer. It has a potential space that may distend with fluid as a result of injury or infection. And this layer allows for free movement of the scalp proper. So the first three layers, you know, the first three layers are the scalp proper. So it allows, the loose connective tissue allows for movement. And the innermost layer of the scalp is the pericranium. So pericranium is a dense layer of connective tissue. It forms the external periosteum of the neurocranium, except where the pericranium is continuous with the fibrous tissue. What are we saying here? Pericranium is the innermost layer of the scalp. And you remember that you have your neurocranium, so it's the layer that covers the neurocranium directly. I hope you are getting that one. Now, having discussed the region of the head, discussing the bones and the bones that form the region of the head and the scalp. So our next discussion shall be centered on the region of the face. The region of the face. You know, the face is also part of the head. Is the anterior aspect of the skull. And the facial bones of the skull form the upper and lower, they form by the upper and lower jaws, the bone of the nose, the nasal cavity, the nasal septum, and the orbit, that is the eye. In all, the facial bones include 14 bones with 6 paired bones and 2 unpaired bones. So for the region of the face, we have 14 bones in all. 6 of them are paired, while we have 2 unpaired bones. Now, brief discussion of these bones that make the region of the face. We have inferior nasal concave. They are things, they are cancellous. So the shape, the shape like leaf. The shape of the inferior nasal concave, they are like leaf. So the lateral wall of the nasal cavity, they form the lateral wall of the nasal cavity, and they are below the superior and middle concave of the ethmoid bone. So for the lacrimal bone, the lacrimal bones, they are also 2. You know, I told you we have 2 paired bones that make up the facial, the facial bone. So for the lacrima, we have the medial wall of the orbit. The lacrima from the medial wall of the orbit, and it's behind the frontal process of the maxilla. They are small, they are thin, they are rectangular, and they contain the depression for lacrimal sac and nasolacrimal tear duct. So from this, you discover that the lacrimal bone has something to do with the orbit, because it is the sacs that within the lacrimal bones that those lacrimal sacs, they have the tears that is when an individual cries, the tears come from the sacs within the lacrimal bones. Now let's move on as we discuss the nasal bone. The nasal bone, they form the upper bridge of the nose. I'm sure you can just begin to imagine even with yourself as I'm discussing it. So the nasal bone forms the upper bridge of the nose between the frontal processes of the maxilla. They are small, oblong, and they are attached to a nasal cartilage. So they form support for the bridge of the upper nose. There are also two. Remember I told you we have 6 paired bones that make the facial bones. So another bone, which is also a paired bone that is bilateral, is the palatine bone. They are posterior parts of hard palates. So they form the floor of the nasal cavity and the orbit. For the palatine bone, they are L-shaped with horizontal and vertical plates. L, if you imagine the letter L, you have horizontal and you have a vertical. So the horizontal plane form the posterior part of the hard palate, while the vertical plate form part of the wall of the nasal cavity, then also the floor of the orbit. I guess you are following me. Then another bone is zygomatic bone, and it is popularly called the cheekbone. The zygomatic bone form the bones of the cheek, and they are lateral to the orbit. They are made up of temporal processes, the zygomatic arc, and the outer part of the eye socket. So we are still on the bones that make the facial bones. Another paired bone of the face is the maxilla. And I'm sure you know this, that the maxilla is the upper jaw and anterior part of the hard palate. It contains the infraorbital foramen and the maxillary sinuses. Also, the tooth sockets are contained in the maxilla. Then they form the upper jaw in front of the hard palate, and they also form part of the eye socket, that is the orbit. Now, having discussed the bilateral bones of the face, we have two singular, that is single bones, and one of them is the vomer bone. Vomer is one, it is thin, and it forms the posterior and inferior nasal septum, dividing nasal cavities. And the last of the bones is the mandible. It is one, that is, it is single. Then the largest and the strongest facial bone, I think you need to take note of that one. It is the largest and the strongest facial bone. It forms the lower jaw, extending from the chin to the mandibular fossa of the temporal bone. So it has two perpendicular rami containing the tooth sockets. I hope we are following. We are still on the aspect of the face. And what we'll be discussing now are the muscles. Though we may not be able to discuss the muscles in details, but let me quickly discuss one of the popular muscles, and it is the orbicularis oculi. So the function of orbicularis oculi is that it closes the eyelid and assists the flow of lacrimal fluid, that is tears. Remember we discussed the lacrimal bone, and I told you lacrimal bone consists of the lacrimal sac, where the fluid, that is the lacrimal fluid, that is the tears, flow from. So the orbicularis oculi muscle closes the eyelid and assists the flow of lacrimal fluid. It is in 3 parts. The first part is the palpebral part. So the function of this part is it gently closes the eyelids. So the palpebral part gently closes the eyelid, while the lacrimal part aids drainage of tears, that is the lacrimal fluid. So the orbital part tightly close the eyelid to protect the eyeballs against injury and dust. So I want to believe that you have gotten the three parts of the orbicularis oris muscle. The palpebra closes the eyelid, the lacrimal part drains the tears, while the orbital part closes the eyelid to protect the eyeballs from injuries and dust. Now, let's quickly discuss the facial nerves. And you know, when we discuss the facial nerves, we discuss the cutaneous, that is the sensory nerve. And so the cutaneous innervation of the face is provided primarily by the trigeminal nerve, while the motor innervation to the face, to the muscles of the facial expression is provided by the popular facial nerve, that is cranial nerve 7. So the motor innervation to the muscles of the mastication is by the mandibular nerve. And that one is from, that is the motor root of the trigeminal nerve. Now, before we move on to the next discussion, I want you to take note of this, that our knowledge of anatomy of the face is essential when it comes to surgeries in the face. Remember, the face is highly vascularized and they are heavily innervated. So any injury to the face can cause hemorrhage, and any injury to the face can cause facial nerve palsy. So the knowledge of anatomy of the face can guide clinicians, nurses inclusive, in avoidance of damage to crucial structures in the face during surgeries and injections in the face. I hope you got that. Now, we are still on the region of the face. Let us discuss the orbit. So the orbit is the bony socket that houses the eyeball. They also contain the muscles that move the eyeball or open the upper eyelid. So the orbit is a pyramidal shaped space that contains the eyeball and its associated structures. It is formed by bones of the skull. Remember, we have discussed that. Then the eyelid and lacrimal fluid secreted by the lacrimal glands protect the cornea and eyeball from injuries and irritation. Now, the eyeball. I'm sure for those of us who are ophthalmic nurse, this would be a form of refresher discussion with you because you are used to it. The eyeball contains the optical apparatus of the visual system. It occupies most of the anterior portion of the orbit, and the eyeballs are suspended by 6 extrinsic muscles that control its movements and a facial sensory apparatus. Let me tell you that the eyeballs, they have 3 layers, and the outer layer, the outer coat, is fibrous layer. The content of the outer layer is the sclera and the cornea, and the middle layer is the vascular layer. So it consists of the choroid, the ciliary body, and the iris, while the inner layer, which is also known as the inner coat, consists of the retina, which has both optic and non-visual parts. So those are the contents of the eyeball. For details, you can go through your lecture notes and you get to read up the details. Because of our time, let's quickly move to the region of the neck. The region of the neck. The neck, as I'm discussing, I want you to begin to imagine, or you begin to even view your own body as I am discussing it. The neck joins the head and the trunk and also the limbs together. So it's like a conduit for those structures that passes through the neck. Now, and I want to say also that several important organs with unique functions are located within the neck. So what are those organs? I'm sure only that I don't want to unmute you for you to mention those organs. If you want to mention those organs that are located within the neck, you remember your thyroid gland and the parathyroid gland, they are located within and around the neck. And as we go in discussion, we'll tell you the organs that actually pass through the neck to get connected to the trunk and other parts of the body. Structurally, the neck has the superficial and deep fascia. So structurally, we have the superficial and deep facial aspects of the neck. Now, let's quickly discuss the superficial cervical fascia. You know, when you talk about the neck, you talk about the cervical spine, you know, because the cervical spine are actually the bony structure of the neck. So for the superficial cervical fascia, it is usually a thin layer of connective tissue that lies between the dermis of the skin and the investing layer of the deep cervical fascia. Now, the superficial cervical fascia contains the cutaneous nerve, the blood and lymphatic vessels. Also, we have superficial lymph nodes, and also there are some degree amount of fat within the superficial cervical fascia. When you view it anterolaterally, it contains the platysma, and you know, platysma is a very strong bone, and it's the bone of facial expression. It arises in the cutaneous tissue covering the superior parts of the deltoid and pectoralis major muscle. Now, let us discuss the deep cervical fascia. For deep cervical fascia, it has 3 layers. So the first layer is the investing layer, then we have pre-tracheal layer, and we have pre-vertebral layer. What the 3 layers do, what they do is that they support the visceral organs. Sorry. They support the visceral organs, that is, the muscles, the vessels, and deep lymph nodes. They also provide the slipperiness that allow the structure in the neck to move and pass over one another without difficulty. So you can, from what I've just said, you can see the function of the deep cervical layer. So they provide the slipperiness that allows the structures within the neck to move and pass over each other without difficulties. Now, we are moving on gradually in our discussion as we discuss the region of the thorax. You know, I told you while we were discussing the body cavity that we have the ventral body cavity, we have the cavity, and I told you the ventral cavity consists of the thoracic cavity and the abdominopelvic cavity. Now, the thorax is within the thoracic cavity, and the thorax is the superior part of the trunk, and the thorax is between the neck and the abdomen. I hope you are getting that one. The thorax is between the neck and the abdomen. Now, the thoracic cavity is surrounded by the important structures like the heart, the lungs, the thymus, the distal part of the trachea, and most part of the esophagus. They are contained within the thoracic cavity. And with this, you know, I want to agree with me that it's a very important structure cavity that we must take cognizance of as nurses. It is conical in shape, and you know, when I say the shape is like cone, the part above is narrow and the part below is broad. I'm sure we want to begin to think why that one is like that. You know, the part above is connected with the neck, and those structures pass through it, and the part below, I told you the part below is broad, is wide. I'm sure the floor of the thoracic cavity, you remember your diaphragm muscle, and you know from that one, is connected with the abdominal cavity. And you know the abdominal cavity is quite broad. So the front part of it, okay, is narrow, while the inferior part of it is broad. Now, let us quickly discuss the thoracic cage. The thoracic cage is also known as a rib cage. So it is formed by the thorax, that is the chest, and it consists of 12 pairs of rib. And you know, when you discuss the 12 pairs of rib, you begin to think about their costal cartilages and the sternum. So the ribs are anchored posteriorly, as if they are anchored to the thoracic cage posteriorly to the 12 thoracic vertebrae. So there is no how you want to discuss the rib without mentioning the thoracic vertebra. You know, there are 12 in numbers, that is T1 to T12. So the thoracic cage protects the heart and the lungs and other structure within the thoracic cavity. Talking about the boundary. So the boundary of the thoracic cage posteriorly, the surface is formed by the 12 thoracic vertebra and the posterior part of the ribs. I hope you are getting it the way I am relating it. Then the anterior aspect of the thoracic cage is bounded by the surface, is bounded by the sternum and the costal cartilages. Then to the lateral aspect, they are formed by the ribs separating from each other by intercostal spaces. Then the superior opening is formed by the first thoracic vertebrae behind and upper margin of the sternum in front and the first rib on either side, that is the lateral sides. Then the lower opening is formed by the 12th thoracic vertebra behind. The 11th and the 12th rib at the sides laterally, and in front, the anterior aspect of the lower opening is formed by the cartilages of the 10th, 9th, and 8th ribs. Now, before I proceed further, there is need for us to know there is an established fact that there is deep difference between the structures of male and male thorax. And let me quickly highlight those differences here. For female thorax, the cavity is less compared with that of, this one is in reference to the thorax of the male. So the cavity is less. The sternum in female are shorter compared with that of male. And the upper margin of the sternum is on the same level with the lower part of the body of the third thoracic vertebrae. Whereas in male, is on the second level. So another striking difference is that the upper rib are more movable for female, and so allow a greater enlargement of the upper part of the thorax compared with that of the male. Put it down. Mr. James, do I project slide? Okay. I will not make you slide. I will not make project slide. You don't teach me that.
Please continue with your lecture.
All right, thank you.
We can hear you. Continue with your lecture.
All right, thank you. Okay. I have just finished discussing the differences between the male and female thorax. So the next thing we'll be discussing is the sternum. The sternum is also part of the thoracic cavity. Remember, we are still discussing the region of the thorax. So discussing the sternum, it is elongated bony structure that anchors the anterior thoracic cage. It is in the anterior aspect of the thoracic cage. It is located in the median line of the anterior thoracic wall, and it consists of three basic portions. The manubrium is the superior portion. So the body is another portion of the sternum. That body, it is the middle and the largest portion. While the lowest portion, the inferior portion, is the xiphoid process. Now, the junction of the manubrium and the body of the sternum forms the sternal angle. Now, let me quickly say something about the manubrium. And from the slide that is displayed, okay, from here, the manubrium on the superior portion has a depression called jugular notch, and and this can be easily felt at the anterior base of the neck, between the medial ends of the clavicle. Now, because of our time, let me go on with the discussion of the rib. In human being, we have 12 pairs of rib that make up the side of the thoracic cavity. You know, I told you the ribs, though, make up the basically they are the lateral aspect, though they progress to the posterior aspect and also to the anterior aspect, but basically they form the lateral aspect of the thoracic cavity, and you know they are remarkably light in weight and highly resilient. So each rib is spongy anterior, interior containing bone marrow. So the interior aspect of it contains bone marrow, and this one helps in a hematopoietic, that is formation of the red blood cells. So each rib posteriorly articulates with the body of its corresponding thoracic vertebra. You know, I told you the thoracic vertebra also forms the posterior aspect of the thoracic cage. So each rib articulates posteriorly with the corresponding thoracic vertebra. I want to believe you understand what I'm saying. So rib 1 articulates with T1 and so on like that. Now, let me mention some common characteristics of the rib. Each rib, regardless of maybe it is false or true, we'll still get to that aspect of our discussion. But each rib consists posteriorly, each rib articulates posteriorly with the body of the corresponding thoracic vertebra that I've mentioned earlier. And also each rib has 2 extremities. It is common to all: a posterior or vertebra end and an anterior or the sternal end. Then there's an intervening portion which is called the body or the shaft of the rib. So these are the common characteristics of the rib: the posterior and the anterior portion, then the body, which is the intervening, is in between the posterior and the anterior portion. Now let's quickly classify the ribs, and we'll classify it using 2 different dimensions. The first dimension is that you classify rib as either true, false, or floating. And for the true ribs, we call it vertebrocostal ribs. They are rib 1 to 7. They are called true ribs because they attach directly to the sternum through their costal cartilages. So because they have an attachment with the sternum through their costal cartilages, they are called true or vertebrocostal ribs. For the first ribs, they are called vertebrochondral ribs, and these ones are rib 8, 9, and 10. So their own cartilages are not directly joined to the sternum, but they are joined to the cartilage of the rib just superior to them. Take for example, the 9th rib joined to the costal cartilage of the 8th rib. So they don't have direct connection with the sternum, but they have indirect connection with the sternum, and that is why they are termed or classified as being false. And the last category in this classification is the floating rib. They call it floating rib, or they call it free rib. They are rib 11 and 12, though sometimes rib 10 can also be classified as a floating rib. Why are they classified as floating rib? They have rudimentary cartilages that do not even connect either directly or otherwise. They are not connected with the sternum. So instead, they end in the posterior abdominal musculature. So that is why they are called floating, because they don't have direct or indirect attachment with the sternum. Now, also rib can be viewed as typical and atypical. For typical ribs, they are ribs between 3, 4, 5, 6, 7, 8, 9. Ribs 3rd to 9, they are typical rib. Why are they called typical rib? There are some features on them that make them typical. And you know, those features can be seen on the head, the neck, and also the shaft. For the head of the, of a typical, I hope you are getting me right. Typical, the head is wedge-shaped and it has two facets. One facet is for articulation with the numerical corresponding vertebra, and the other is for the vertebra superior to it. So it attaches, it has two points of attachment. The first one attaches to, okay, let me just take the third rib as an example. So for the head, the first facet attaches to the third thoracic vertebrae, while the second facet articulates with the vertebra superior to it. So what I'm trying to say in essence is that, taking that third rib as an example, the first facet articulates with the T3, while the other facet articulates with T4. I hope you got that one right. Now, what makes the neck of a typical rib? What's the difference is that they connect, the neck connects the head with the body at the level of the tubercle. So the neck connects with the body of the rib at the level of the tubercle. And for the body or the shaft, it is thin, flat, and curved. So these characteristics make ribs 3 to 9 typical. Now, let's now discuss atypical ribs. Atypical ribs, they don't have those characteristics that have been mentioned before, and the ribs that are grouped under this are the first rib, the second rib, the 10th rib, the 11th rib, and the 12th rib. So how many are they in all? There are 5 in all. So the first rib is atypical because it is the broadest, shortest, and most sharply curved of the 7 true ribs. Remember, first rib, though being atypical, is a true rib. Anyway, you don't have to be confused. And if you are confused, you have to go back to your study material and read very well. For the second rib that is atypical is the second rib. Another rib that is atypical is the second rib. In this case, the second rib is thinner, is less curved, and much longer than the first rib. It also has 2 facets on its head for articulation with the bodies of T1 and T2 vertebrae. Then ribs 10, 11, and 12, they are atypical because, like the first rib, they have only 1 facet on their head for attachment. And also rib 11 and 12 are short and have no neck or tubercles. So these characteristics that I've just mentioned made ribs 1, 2, 10, 11, and 12 atypical. I hope you have gotten that. Now let's discuss the costal cartilages. The costal cartilages are the basophiling cartilage which serve to prolong the rib forward and contribute very to the elastic of all of the thorax. So the cartilages, the costal cartilages, they contribute to the elasticity of the thorax. So the first 7 pairs are connected with the sternum. Remember your true ribs. So the first 7 pairs of costal cartilages are connected directly with the sternum. So the next 3 are they articulate with the lower border of the cartilage of the preceding rib, while the last 2 have pointed extremities which end in the wall of the abdomen. So like the ribs, the costal cartilages vary in their length, breadth, and direction. Well, that's that about the region of the thorax. Let's quickly move to the region of, the heart. Heart is not a region, but it's an organ located within the region of the thorax, that is the thoracic cavity. I am sure even from our knowledge of basic anatomy in schools of nursing, I don't have to dwell much on this organ called the heart. It is located within the thoracic cavity and medially between the lungs in the space that is called mediastinum. So the heart pumps blood through the network of arteries and veins known as the cardiovascular system. Where if you can view my slides, okay, I can see that you can view my slide. if you can view my slide, you see that structure on your screen. That is structure of a typical heart. And let me just refresh your memory before we move on to the circulation through the heart. So the heart, remember, it has compartments. It has the right side and the left side, the right and left atrium, or let me say atria, the right and left ventricles. And you remember those blood vessels that are associated with it, the aorta, the inferior vena cava, the superior vena cava, and the likes. I'm sure you can vividly describe the structure of the heart, and I wouldn't really bother myself to go deep into that. But briefly, let's go to the circulation through the heart. And even this one is also a form of refresh. It's like I'm just refreshing your memory, because even from our knowledge of basic anatomy in our various schools of nursing, we know we should, let me say, don't let me assume, but we should be able to discuss the circulation through the heart. But for those of us who might have forgotten or may not be able to follow the trend, let me quickly say, and that is why I use arrow to make illustration on the slide you are viewing on your screen. So the circulation through the heart, you remember I told you, you have the right side of the heart and the left side of the heart. And remember that after oxygenation, and you know it's a form of a cycle. After oxygenation, when blood, the deoxygenated blood, that is blood that is low in oxygen, are deposited into the right atrium by inferior and superior vena cava. Remember, the superior vena cava brings blood from the upper aspect, the superior part of the body, while the inferior vena cava brings blood from the lower part of the body. And the two veins, they bring their content into the right atrium. I think you can see the arrow. Now, in the right atrium, there is a valve that prevents the regurgitation of blood, from flowing back. And you know, tricuspid valve is located between the right atrium and the right ventricle. So so when the blood leaves the right atrium, it ends bellunar, and you know, when the blood gets to the lungs, remember, hello, audio mi ti lọ. Okay. Ṣé o ti wá padà ni? Okay. So sorry. I hope you can get me. You can hear me now. Well, let me just assist in the lungs, where the carbon dioxide from the blood are exchanged for oxygen. So that blood rich in oxygen and nutrient are now carried by the pulmonary veins to the left atrium. And when the blood gets to the left atrium, bicuspid valve give way for the, to ejaculate to the body. So, the aorta gives branches. We have the descending aorta that supply the organs in the lower aspect of the body. Remember, the heart itself has to be arteries. They are also branch of the aorta. They also give nutrients to just circulation. Pump is the pump that gives blood to the entire body, but it also has to be supplied with blood and nutrients. So that is just it. And the screen you are viewing on the screen, okay, the next screen you'll be viewing now is just the screen of the heart that shows how the heart is also being supplied with its own nutrients. And you know, I told you that blood that is high in nutrients and oxygen gets to the aorta, and aorta supplies the rest of the body. So the aorta gives out a branch known as right coronary artery. It supplies the right side of the heart, and also we have the circumflex artery. We have left anterior descending artery, popularly known as LAD. So it's also, they all supply the heart, and you know, the venous drainage is by nutrients and blood. That is coronary circulation. Now, our time is fast spent, but I want us to quickly discuss the bones of the upper limbs. And from the screen, you can view from your slide. Are we there? Okay. The next slide you'll be viewing is okay. We are there. So the next slide, this slide you are viewing on your screen now is the slide of the bones that make up the upper limbs. And from that image, you can see the clavicle, you can see the scapula, you can see the humerus, the ulna and radius, and the bones that make up the hands. I will just briefly mention those ones. They are in your lecture and read them. For the clavicle, it is called the collarbone. I'm sure you know that, and you know it has it articulates with the shoulder blade called the scapula. So it has an articulation, and it's very essential because you know it's also there are muscles that articulate with the collarbone, and you know it is very, and it makes the upper, especially the pelvic girdle, to be stable. It provides stability. The muscles that are attached to it provide stability for the bones of the upper limbs. So any injury, fracture to it, you know, it calls for a great concern. And for the scapula, you know, the scapula and the clavicle, they articulate with the bones of the thorax at one point only, and it is called sternoclavicular joints. So the clavicle and the scapula, they articulate with the bones of the thorax at sternoclavicular joints. So the lateral end of the clavicle articulates with this projection on the scapula. So, and the projection is the acromial process, forming acromioclavicular joint. So there is a joint between the clavicle and the scapula called acromioclavicular joints. Now, let me quickly rush to discussing the humerus. For the humerus, you know, it's from the bone of the upper arm. The humerus from the bone of the upper arm, and it's a long bone. I'm sure when we are discussing the long bone, we discuss it as having the head, as having the upper part and lower part, the upper extremity and lower extremity. We discuss it as having a body. The proximal part of it is the head. We say it has a body, and the proximal part of it, which is the head, articulates with the scapula at the glenohumeral joints. I'm sure you are getting that. And so the shaft of the humerus, it is rough, and it provides attachment for for muscles, especially the deltoid muscles. You know, there is a deltoid tuberosity on its lateral aspect, that is the lateral aspect of the humerus. So it provides attachment for the deltoid muscle. And the medial aspect of the humerus has a large medial epicondyle. So the articulating surface of this distal humerus consists of the trochlea, medially. I'm sure you must be relating what I've told you, I've discussed earlier with you, depending on humerus that accommodate the forearm bones during bending. You know, when you bend the humerus, the forearm, we say you are flexing. When you bend it, we say you are flexing the hand, and when you straighten it, we say you are extending your elbow. So these are the features of humerus. You can get the details in your lecture notes. Let's quickly move on to the forearm. So the forearm, there's also a region in the upper limb, and it is located between the elbow and the ribs. So anything between the elbow joints and the ribs, they form the area or the region known as the forearm. And in this compartment, we have two bones. We have the ulna and the radius. You know, the ulna is medial, while the radius is lateral. And how you can actually get to know it better is that the radius is towards the thumb. So the lateral aspect of it, so you can discover that the radius is at the lateral aspect of the hand, because, you know, considering the terms I've taught you, the thumb is at the lateral aspect of the body. Now, the elbow joint is formed by the articulation between the trochlea of the humerus and the trochlear notch of the ulna and the head of the radius. I hope you got that one. If you are discussing the elbow joints, you see all the connection that make the joint, and one of the reasons that makes the elbow joint to also be one of those the articulation between the head of the radius and the radial notch of the ulna. Now, the proximal ulna also has olecranon process. Sorry. So I'm talking about the olecranon process, and this one forms an expanded posterior region and the coronoid process of the ulnar tuberosity on its anterior aspect. Because of our time, I have to rush. All these things are contained in your lecture notes just for us to just do a form of revision. So for the bones of the hands, the bones that form the hands, they are called the carpal bones, and they are 8 in number. So the bones that form the hands, they are arranged in 2 rows. So the proximal row contain, you know, when I'm talking about the proximal row now, you view it from lateral to the medial. They contain the scaphoid, the lunate, the tricutrium, and the pisiform bones. That is the first row. So the distal row contains the hamate, the capitate, the trapezoid, and the trapezium bones. So those are the bones that form the hand. And in totality, we have been able to discuss to mention the bones that form the upper limbs, and go to the bones that form the lower limbs. The bones that form the lower limbs, from the slides you are viewing on your screen, the bones that form the lower limbs consist of the femur, of the foot, and the toes. And from that slides you are viewing on your screen, you can see that there is an articulation between the pelvic bone and the first part of the bones that form the lower limbs, that is the femur. And you know that femur is painted red for easy recognition. And you know there's also articulation between the femur and the tibia and fibula. And also we can see the tarsal bone, the tarsal bone, the metatarsal bone, and the phalanges. All these ones, they form the bones of the lower extremities. And let me just talk briefly on this. The bones of lower extremities, they are in 3 compartments that I have mentioned. The first compartment is the thigh. So the thigh, and the bone that we can see within the thigh is the femur bone, and it is located between the hip and the knee joints. So the femur is between the hip and the knee joint. And another compartment is the leg compartment. And the leg compartment, they are bones that can be seen between the knees and the ankle joints. And those bones are the tibia and the fibula. So there is what is called decap, which is a patella, and also the bones of the foot and the phalanges. Now, femur, I'm sure if I ask you to discuss the femur, I'm sure you tell me femur is a very long bone. Femur is a very long bone of the lower extremity. It has an head, it has neck, and it has a head that articulates with the acetabulum of the hip bone to form the hip joint. It has a surgical neck and all that. I'm sure you are used and you can describe all those fissures on the femur. Now, the patella is also a very important structure when we discuss the bone of the lower limbs. And it's a sesamoid bone, and it is located within the muscles and the tendon. It's articulated with the patellar surface of the anterior side of the distal femur, thereby protecting the muscle and the tendon from rubbing against the femur. So you can see the importance of the patella. So it prevents the friction. It prevents a friction in that part of the joint. And the tibia and fibula, they form the bones of the leg. And we have the tibia is very large and strong, whereas the fibula is thin. And the tibia actually bears the weight of the body. Fibula doesn't really have anything to do with weight bearing, but it also helps in attachment of muscles. Now, the proximal tibia consists of the expanded medial and lateral condyles, which articulate with the medial and lateral condyles of the femur to form the knee joint. So those are the striking features on these bones. So between the tibial condyles is the intercondylar eminence. So on the anterior aspect of the proximal tibia is the tibia tuberosity, which is continuous inferiorly with the anterior border of the tibia. Now, on the posterior posterior side, the proximal tibia has the curved line, and the bony expansion on the medial side of the distal tibia is the medial malleolus. So the groove on the lateral side of the tibia of the distal tibia is the fibular notch. Now, for the fibula forms the proximal end and articulates with the underside of the lateral condyle of the tibia. Then the distal fibula articulates with the fibular notch of the tibia. And that is just that about the bones of the leg, the tibia, and the fibula. And lastly, let's discuss the bones of the foot. So the posterior aspect of the posterior foot is formed by 7 tarsal bones. So the talus articulates superiorly with the distal tibia. So the medial malleolus of the tibia and the lateral malleolus of the fibula to form the ankle joint. Can I just take that one again? The talus, talus is part of the bones of the foot, and it articulates superiorly with the distal part of the tibia. Then it also articulates with the medial malleolus of the tibia. It articulates with the lateral malleolus of the fibula to form the ankle joint. So the talus articulates inferiorly with the calcaneus bone. So anterior to the talus are the navicular bone, and anterior to this are the medial, intermediate, and lateral cuneiform bones. So the cuboid bone is anterior to calcaneus. Those bones that I'm just mentioning, they are the bones that form the foot. And lastly, we have 5 metatarsal bones that form the anterior aspect of the foot. So the base of these bones articulates with the cuboid bone. Then the metatarsal bones are at their distal end articulate with the proximal phalanges of the toes. The big toe has proximal and distal phalanx, and the remaining toes have proximal, middle, and distal phalanges. So only the big toe has proximal and distal, but for the remaining toes, they have proximal, they have middle, and distal phalanges. And I would implore you to read the innervation to both the lower and the upper limbs, also the muscle attachments. And on these notes, I want to say thank you for joining us on the online facilitation for ANA 212. So I'm sure Mr. James will anchor the aspect of question and answer.
Hello. Okay, thank you for a wonderful presentation. So if you have questions now, you can now try to raise your hand. So we may not entertain more than 5 questions for today. So let me start with Genevieve, your question.
Good morning, sir. Good morning, ma'am.
Good morning. I'm all ears. You can ask your question.
Okay. Please, my question is from the beginning, study session 1.
From the beginning, I'm listening.
Yes, the study question 1.
Your network is breaking.
Okay. Hello, can you hear me now? Hello? Hello? I do not get the cavities of the body cavity. I don't understand them.
Yes, I can hear you.
Okay. The
I
planes
am listening.
The planes, I did not get the planes, your explanation on the directional terms, in fact. Where you
Hello?
I did not understand your explanations on the directional terms, the planes and the cavities.
All right. Okay.
Okay.
When we talk about okay. When we talk about the directional terms, just like I told you, they describe the position in relating to another structure. So you describe position relating to another structure, and that is where I mentioned those terms like superior, inferior. I mentioned terms like medial and lateral, proximal and distal. And you know, I told you that for the superior, it's relating to structure above a particular organ, and most of the time it relates to the head, while the inferior relates to the structure below a particular organ. And you know, for you to actually use these terms, you must have 2 things you want to compare. You know, like I cited the example of abdominal cavity. Abdominal cavity is superior to pelvic cavity. The thoracic cavity is superior to abdominal cavity. So you must have 2 organs or 2 structures you want to compare if you want to use those terms. And for I think you also mentioned the plane. I know when I discussed the planes, I told you planes are just imaginary lines. You know, they are imaginary lines that are drawn. They are drawn to divide body into sections. And I told you basically we have 3 planes. We have the sagittal planes, and that sagittal planes divide body into right and left sides. We have the frontal planes that divide body into the anterior and posterior aspects, while we have the transverse planes that divide body into the upper and lower portion. Then, talking about the cavity, I told you we have cavities of the body. Basically, we have the ventral cavity, which is also known as the anterior cavity. We have dorsal cavity. I told you the ventral cavity consists of the thoracic cavity, the abdominopelvic cavity, while the dorsal cavity consists of the cranial cavity and the spinal cavity. I don't know if I've answered your question.
Thank
Hello?
you.
Okay.
Thank you.
So, any other question?
Samuel Temitope. Samuel Temitope.
Nafisat Omotoso.
Okay, good morning, ma.
Good morning.
My question is basically on section 2, which is talking about the facial bone. Can you hear me, ma?
I can
The
hear
facial
you.
bone,
Your network,
the
your
element
network
on
is
the
breaking, but
facial bone made up of 14
okay.
bones. Now, on the slide presented,
Okay.
it was 15. That means the ethmoid bone was added to it. So I want to confirm that does the ethmoid bone make up of the facial and the cranial bone too? Please clarify that, ma'am.
Actually, okay, is that all? Actually, ethmoid, some part of the ethmoid also form part of the facial bone, though the bulk of it is the bulk of it is on the bones of the skull, but because there is a portion of it that also form the part of the facial bone, and that is why it was mentioned. It was just mentioned for descriptive purpose, but basically it forms it's part of the bones of the skull. Have I convinced or confused you?
Thank you.
Hello?
Uche.
No, I don't know if she is confused or I don't know if
can't
she's
talk
confused.
again. So
Okay. All right. Any other question?
Olubumi, Oluokun, your question.
Okay, thank you, sir. Thank you, Ma, for the presentation. My question is on ribs. When you explain the head of the typical ribs, you explain that the one facet articulates with the corresponding vertebra, and you gave example of the third articulating with the tip rib. Now, the note says one facet is for the vertebra superior to it. When you explain the other facet, you said it articulates with T4. But with my understanding of the note, if it articulates with the vertebra superior to it, that makes it T2, not T4. That's my question, ma.
Okay, let me. All right, you are talking about when I was explaining the true ribs, Abi?
Yes,
hello?
The typical ribs.
Typical rib. So I want to get your question clearly. That I said it's typical ribs has two facets for articulation. One for its corresponding thoracic vertebrae, and I made example of because rib 3 is typical rib, is a typical rib. Okay. Hello?
Yes, ma'am.
So I said one facet is for the articulation with the numerical corresponding vertebrae, and the other facet is for the vertebrae superior to it. So, okay, I could get you. Okay, in my presentation, I said T4. It should be T2. It should be T2. It should be T2. Thanks for that observation. It should be T2. Is that clear? Okay. All right. Any other?
Uche, your question.
Okay. Good morning, ma. My question is on the sternal angle. I want to know the composition. What consists the sternal angle?
The sternal angle. Let me get back to my slide. But you know, the sternal angle is a junction is a junction between the sternum and, I mean, between the upper part of the sternum and the body of the mandible and the body of the sternum. So it's that junction that make it an angle. So that is the sternal angle. I don't know the composition you are talking about. It's just an angle. And if you could, okay, you don't have access to that slide again, but you can actually check through your lecture notes and check through other diagrams in textbooks. So you see that that angle is between the mandible and the body of the sternum. Hello?
Yeah. Uda,
Good morning, ma.
can you speak louder?
Good morning, ma.
Good morning.
Yes, ma. Thanks very much for the lecture. My question is about the you stated some differences between the male and the female what is it called?
Thoracic.
Yes, thoracic cavity. Please, can you help me expatiate more on it? I couldn't get it. And also about the bones forming the ankle.
Everything I mentioned about the differences between the female and male thorax are in your lecture notes. They are, in fact, they're actually lifted, so you can go through your lecture notes. And also for the bones that make up what your second question. Hello. So you can actually go through your lecture note for it. But for the difference, I told you the capacity of the female thorax is less, while that of the male is much bigger. The sternum in female is shorter compared with that of male. They are in your lecture notes, so you can go through them.
Then lastly, Oluwapelumi Bishop.
Good morning, sir.
Good morning.
Hello.
Good morning.
Hello. Good morning. Good morning,
Good
ma.
morning. I'm listening.
Yes, ma. Ma,
go ahead with
ma,
your
during
question,
your
please.
okay, ma. Ma, during your lecture, ma, you under the region of the heart, you didn't. I don't know whether you intentionally skip a conducting system of the heart, ma. Because when I was reading it, I didn't get it very well. That's why I'm asking about that one, ma.
I'm so sorry. I actually skipped it because of time. One, and the conducting system of the heart is actually basically physiology. It's basically physiology, and this is anatomy. Well, and there is nothing much about the conducting system of the heart. Is that it's a kind of electric activities of the head of the heart, and you know it involves some nodes, the SA node and the AV nodes. And you know, for it to actually work well, the muscle, especially the cardiac muscle, also has to function well, to contract very well, because the electrical activity of those nodes actually work on the cardiac muscle to do what? To contract very well. And you know, the SA node is known as the pacemaker. It is in the anterior, it is in the right atrium. So when it is triggered into action, it allows the right side of the heart, the right atrium, to do what? To contract. And you know, the waves of contraction goes to the AV node. So the AV node is also stimulated, and it sends its own wave to the Purkinje fibers, and you know, the wave spreads through the heart, and you know, it's a form of a cycle. And you know, having been triggered and those triggers goes round like that, it forms a complete cardiac cycle, and another cycle also begin. You can, I don't know which aspects you need clarification on, but it's basically physiology. It's basically physiology, not anatomy. And one of the reasons why I didn't really dwell much on it, because either during your systemic and functional anatomy you have been taught, or you were taught, or you have been taught during physiology class, but it's basically physiology. Thank you. Hello.
Okay, thank you. We have come to the end of the class, but before we go, I can see some of you are asking questions through the chat, asking if the question will be true or false, filling the gap. Just prepare, read from what they call it, read everything in your study materials. In addition to this one, the slide you are, the face-to-face facilitation you have been done today, add it together. This one is not supersede the one on your manual. Why the one on your manual is not override this one? They are together. And you can as well do more by checking the internet, read more textbook on the regional anatomy, so that you can have a wide knowledge, not because of this exam, but because of your career. Thank you. If you have any other question, you can reach your facilitator online, either through the WhatsApp or SMS or through the LMS. Thank you and have a lovely day.
All right, thank you, students. All the best in your exams. Go below. I said, leave class.